For this video, we will be going over pancreatitis and several example agents and their mechanisms behind drug-induced acute pancreatitis, which you may see abbreviated as DIAP. So the pancreas is responsible for the synthesis and secretion of a number of enzymes that are hydrolases that are needed to digest the contents of a meal. So these include enzymes with protease, lipase, nuclease, amylase, or other hydrolytic functions. These enzymes are synthesized by pancreatic acinar cells, which I'm showing you a zoomed in version here. And once they are synthesized, they are then stored in secretory granules until they are released in response to a variety of secretory signals. And just as a heads up for this video, we won't get into the details of this regulation and these signals. So these hydrolytic enzymes are synthesized as inactive proenzymes or zymogens. And once released, these zymogens are activated through proteolysis and cleavage by enzymes that are found within the small intestines, like enterokinase. And this activation only occurs after the secretion of these zymogens and release from the acinar cells into the pancreatic duct, which then combines with the bile duct to then empty into the duodenum to then interact with that enterokinase, become cleaved and activated to then be able to aid in digestion. So we will use trypsinogen as an example. So in the acinar cells, trypsinogen is packaged after synthesis into granules. It is secreted from the acinar cell to then travel down the pancreatic duct to then enter into the small intestine, interact with enterokinase to become activated, and its activated form is trypsin. And then it can cleave and activate the remaining zymogens that are synthesized and secreted with it from the acinar cells. And this causes that enzyme activation cascade to help digest meals. So moving to the next slide. Now, this is how the exocrine function of the pancreas should work. But in the presence of certain drugs and other substances that won't be the focus of today, this key pancreatic function is disturbed. This leads to the inappropriate and premature activation of digestive enzymes in a location that leads to autodigestion of the pancreas. And this will trigger the immune response and inflammation, leading to pancreatitis. Now, there are three primary ways in which an offending agent can lead to drug-induced acute pancreatitis. And we will get into those on the next few slides. So moving on to the next slide. The first way in which a drug can induce pancreatitis is through some mechanism that promotes duct obstruction. Now, this can be agents that promote the formation of gallstones that can become lodged at this point where the bile and pancreatic duct converge, and this would prevent that flow of secretions into the duodenum. So the zymogens instead remain in the pancreas, where they can become auto-activated and then begin that auto-digestion cascade. This can also be from agents that lead to edema and or inflammation in this region, similarly obstructing that secretory flow, leading to the same outcome of pancreatitis. One example would be the angiotensin converting enzyme inhibitors, or the ACE inhibitors, like lisinopril, or the other agents that will similarly end in PRIL. These inhibit the conversion of angiotensin 1 to angiotensin 2, and this will lead to downstream blood pressure lowering effects. Now, the angiotensin converting enzyme is also responsible for the degradation of bradykinin to its inactive form. Bradykinin is a potent pro-inflammatory peptide that is released under certain circumstances, but when it is not inactivated appropriately by angiotensin converting enzymes, because, for instance, there is an ACE inhibitor on board, there is an inappropriate buildup of bradykinin that can lead to angioedema, where there is a lot of vasodilation, inflammation, and edema, leading to an obstruction here. So when the zymogens are secreted in the pancreas, they get backed up, they hang around to be inappropriately activated, and begin digesting the pancreatic tissue, leading to more damage and inflammation. Now, ACE inhibitors and their mechanism behind pancreatitis is just but one example of how duct obstruction from a drug's effects can lead to pancreatitis. So moving on to the next slide. The second way in which a drug can trigger acute pancreatitis is through the alteration of intracellular transport of these secretory granules in the pancreatic acinar cells. So if the granules cannot fuse with the cell membrane to then be released, then the granules risk remaining in the acinar cells for a prolonged period, increasing the risk of them fusing with lysosomes. The fusion with lysosomes will lead to intracellular enzyme cleavage and activation. And then these activated enzymes that are intracellular will be free to auto-digest their acinar cell home and then move on to neighboring cells once they make it through the cell membrane and into that extracellular space. One way that we can get this intracellular transport defect is through a number of drugs that cause hypercalcemia. So calcium is one of the most important signaling components in the acinar cells, and it is necessary for translating the stimuli to trigger granule transport and secretion. Now, calcium spikes are released from intracellular stores to promote this normal secretory process. However, in hypercalcemia, the high extracellular calcium translates to sustained high intracellular calcium, but it's in the cytosol now. So without calcium spikes and now this new sustained hypercalcemia, this triggers a secretory block. So these granules linger intracellularly, potentially fusing with the lysosomes to activate that autodigestion cascade. So one agent that can lead to hypercalcemia is hydrochlorothiazide, and you might see this abbreviated as HCTZ. And hydrochlorothiazide is a thiazide diuretic, and their mechanism in the kidney is thought to lead to an increase in calcium reabsorption from the urinary filtrate back into the bloodstream, leading to potentially hypercalcemia. So there are a number of other agents that can also alter calcium levels to affect this transport process and potentially lead to pancreatitis. Moving to the next slide. Now, the third way a drug can trigger pancreatitis is through acinar cell injury. And this would be independent of an intracellular transport defect. So think of this more as a direct injury to another cellular component that will lead to this inappropriate activation of digestive enzymes and autodigestion. For example, this can be from drugs that lead to the formation of toxic metabolites or reactive oxygen species that deplete antioxidant pools and lead to cellular damage. So this would be agents like ethanol and statins, both of which we talked about their toxic effects in the alcoholic liver disease video and the rhabdo video. And a similar toxic mechanism that we talked about in these videos is thought to be in play here with their induction of pancreatitis. So a number of other agents we haven't talked about are thought to form toxins or reactive oxygen species that can inflict acinar cell damage as well. Another example that would fall in this category would be agents that cause high triglycerides or hypertriglyceridemia. And generally, a triglyceride level of greater than 1,000 is concerning for acute pancreatitis. Now, if you think back to the video on hyperlipidemia, remember lipoprotein lipase is an enzyme that's found in capillary lumens that hydrolyzes triglycerides to free fatty acids. Well, when these lipases act upon extremely high serum triglyceride levels in the blood, free fatty acids are released, and they can have toxic effects, especially at high levels. So these toxic free fatty acids can trigger the inflammatory response in the pancreas, leading to ischemia in the capillaries and damage to the acinar cells. So the cellular damage will eventually lead to either the premature intracellular or extracellular activation of those digestive enzymes, triggering further acinar cell damage and inflammation and so on. Now, exogenous estrogens, like those in oral contraceptives and hormone replacement therapies, can increase triglyceride levels and free fatty acid levels by decreasing the clearance of triglycerides, and this is through a reduction in lipase expression and lipoprotein expression in the liver. And hydrochlorothiazide, in addition to its risk of inducing hypercalcemia, can also cause high triglycerides, leading to two insults, increasing the risk of hydrochlorothiazide-induced acute pancreatitis. Moving to the next slide. As you can see from the examples we've gone over today, all of these agents initiate this deleterious cascade in unique ways, but the overarching theme is that they all lead to the inappropriate and premature activation of digestive enzymes in a location that leads to autodigestion of the pancreatic tissue. This will trigger the immune response and pancreatitis. So pancreatitis is one of those severe adverse drug reactions that you should be aware of. And if you understand the pharmacology behind some of the agents that can induce or that predispose patients to this condition, you can use that information to predict what other drugs could be risky either alone or in combination.